Chapter 5 RBC Disorders. Macrocytic anemia. Macrocytic anemia is also called megaloblastic anemia. Anemia with MCV more than 100 cubic micrometer. Causes include folate or vitamin B12 deficiency. Folate and vitamin B12 are necessary for synthesis of DNA precursors. Folate circulates in the serum as methyl tetrahydrofolate. Removal of methyl group allows for participation in the synthesis of DNA precursors. Methyl group is transferred to vitamin B12 cobalamin. Vitamin B12 then transfer it to homocysteine, and homocysteine is converted to methionine. Lack of vitamin B12 or folate impairs synthesis of DNA precursors. Impaired division and enlargement of RBC precursors leads to megaloblastic anemia. The RBC precursor undergoes one less division, so in this way the cell is going to be larger than usual. It occurs due to upset in the production of DNA precursors. It occurs due to deficiency of the folate or vitamin B12 or both. Impaired division of granulocyte precursor lead to hypersegmented neutrophils. Normally in neutrophil, the lobes of nucleus is ranging from 3 to 5, but due to deficiency of folate or vitamin B12, its lobe increases from 5. So in this way, it is called hypersegmented neutrophils. Megaloblastic change is also seen in rapidly dividing, e.g. intestinal epithelial cell. Other causes of macrocytic change without megaloblastic change. Megaloblastic change is only occurred due to folate or vitamin B12 deficiency. Include alcoholism, liver disease, and drugs. Folate deficiency. Dietary folate is obtained from green vegetable and some fruits. Absorption occurs in the jejunum. Folate deficiency develops within months as body stores are minimal. Causes include poor diet, e.g. alcoholics and elderly, increased demand, e.g. in pregnancy, in cancer. In cancer, there is rapidly generating new cells and their nuclear material needs an increased demand of folate. Hemolytic anemia. In hemolytic anemia, the bone marrow needs an increased demand of folate. And folate antagonist, e.g. methotrexate, which inhibits dihydrofolate reductase enzyme, which are necessary for the synthesis of folic acid. Clinical and laboratory finding includes macrocytic, RBC, and hypersegmented neutrophils, glossitis, decreased serum folate, increased homocysteine level that increase the risk for thrombosis. Due to deficiency of folic acid, homocysteine is not converted to methionine. That is why in serum the level of homocysteine rises. Normal methyl malonic acid. That is the picture of hypersegmented neutrophils. Vitamin B12 deficiency. Dietary vitamin B12 is complex to animal-derived proteins. Salivary gland enzyme e.g. amylase liberates vitamin B12, which is then bound by air binder also from the salivary gland and carried through the stomach. Pancreatic proteases in the duodenum detaches vitamin B12 from the air binder. Vitamin B12 binds to intrinsic factor made by gastric parietal cell in the small bowel. The intrinsic factor vitamin B12 complex is absorbed in the ileum. Vitamin B12 deficiency is less common than folate deficiency. It takes years to develop due to large hepatic stores of vitamin B12. Pernicious anemia is the most common cause of vitamin B12 deficiency. Pernicious anemia includes autoimmune destruction of parietal cell that is present in the body of stomach that leads to intrinsic factor deficiency. Other causes of vitamin B12 deficiency include pancreatic insufficiency. As we know that protease is produced by the pancreas. In pancreatic insufficiency, there is no protease secretion, so intrinsic factor does not bind to vitamin B12 and result in vitamin B12 deficiency. Damage to terminal ileum, e.g. in Crohn's disease or diphyllobothrium laterum fish tapeworms, or dietary deficiency. Clinical and laboratory finding includes macrocytic RBC with hypersegmental neutrophil glossitis, subacute combined degeneration of the spinal cord. Due to deficiency of vitamin B12, methylmalonic acid deposit in the myelin of spinal cord and result in degeneration of certain region of spinal cord. Vitamin B12 is a cofactor for the conversion of methylmalonic acid to succinyl coenzyme A, important in fatty acid metabolism. Vitamin B12 deficiency results in increased level of methylmalonic acid, which impairs spinal cord myelination. Damage results in poor proprioception and vibrative sensation, posterior column, and spastic paralysis, lateral corticospinal tract. Decreased serum vitamin B12, increased serum homocysteine, similar to folate deficiency, which increases risk for thrombosis. Increased methylmalonic acid, unlike to folate deficiency. The investigation of choice for vitamin B12 deficiency is increase in urinary methylmalonic acid.